Invitada viene de Estados Unidos, de Los Ángeles, California, del Keck School of Medicine de la Universidad de Southern California. Es profesora asociada y además es la directora del programa de Medicina de Urgencias de esa universidad. La doctora SHOENBERGER se ha dedicado a investigar acerca de los cuidados paliativos en medicina de urgencias, un tema con el que muchos no están familiarizados, ya que pareciera que este tipo de pacientes no tiene cabida en nuestro servicio. Hoy ella nos demostrará lo contrario en su conferencia acerca del paciente moribundo. Siempre hay algo que hacer. Doctora.
All right, muchas gracias. Buenos dias. My name is Jan. It's very nice to meet all of you. Thank you very much for the invitation to be here. Today, I'm going to talk about a very important part of living, which is dying. And in the emergency department, we sometimes take care of patients at the very end of their life. And it's an area for me of much interest because I think that we can improve our care of the patients at the end of their life. And sometimes we do this in the emergency department. This is an area where I have some expertise, and I hope to share some of that with you this morning. So what I want to talk about today in the next 30 minutes is to describe the things that people exhibit when they're dying. What does a patient look like when they are near death in the last hours to days of their life, and how we can recognize that, and how we can manage that person in the emergency department, including their symptoms, to make them as comfortable as possible. We're going to talk a little bit about family and how important family is, and our personal preferences when it comes to the end of life. Now, there are some other topics in this area that are very important that include terminal extubation, so taking someone off of a ventilator. Sometimes we make a choice to do that in the emergency department. That's a different topic, and we're not going to talk a lot about the skill of having some of these conversations because that also is a very difficult area. We're going to talk a little bit about that, but not in great detail. So, why does a patient who's dying at home end up in the emergency department? How does that happen? Well, sometimes there are specific reasons why this happens. One could be that the caregiver or the family wasn't expecting death to come. They weren't expecting that it was going to happen today or soon, and they become upset about what's happening at home. Sometimes they actually know that their family member is going to die, but they become distressed and they come to the emergency department. Or patient might be having symptoms that the family feels they cannot manage at home. So they end up in the emergency department. And so now you are in charge of taking care of someone in the last hours of their life in a place that's not designed very well for doing this. We as emergency physicians are used to taking care of patients with a snapshot type view. We see them in a single moment of time, and we make decisions about what to do in this moment. How do they look? What do they come in with? And really, a patient's symptoms are part of a movie, more of a story. And in fact, as someone is dying, this is part of a story, part of a decline. And so we have to open our minds to what was happening in the days and weeks before they came to the emergency department so that we could recognize that they're going to die soon. We work in a very busy environment. We're used to intervening, making decisions quickly, and doing something. And sometimes our patients, that's not the right decision. In these patients, the idea is to listen and to think about what we can do, but to do the right thing for that patient in that moment of time. This can be difficult because we are constantly being interrupted. Our phone is ringing, we're being paged, we're trying to document. We work in a very chaotic environment, and this type of care is very challenging, but something we are often faced with. So, how many of you have really seen a patient as they're about to exit this world? And we're talking about patients who have cancer, terminal illness, organ failure, patients who have been a slow decline for a while. These are some of the physical signs that someone is nearing death. And they are reliable physical signs, but we don't know often exactly how long someone has left to live. But someone who is becoming less and less conscious, someone who's becoming more drowsy, more unresponsive to our verbal or tactile stimuli, they're talking less, decreased ability to communicate with us, shorter sentences, monosyllabic words. and delayed response are all signs that someone is nearing the end of their life. And then we have a stage called terminal delirium, which is almost like an agitated, dreamlike state where someone might be moaning or groaning or restless or agitated or may have purposeless, repetitive movements as they're processing what's going on. And their respiratory dysfunction. As the systems in the body start to shut down, different changes are observed. In terms of the respiratory system, they often have abnormal breathing. It can be rapid and then slow. They may have some agonal breaths. They have abnormal breathing patterns. They may lose the ability to swallow at the end of life. They may find themselves gurgling on secretions. This can be very upsetting to family members. We'll talk about how to manage that. They may lose their gag reflex. They may lose sphincter control and have incontinence of their urine or bowels. They may be having pain at the end of life. And how do you assess that patient that can't communicate their needs in terms of pain to you? And they may lose their ability to close their eyes completely. All of these things are signs to you that someone is withdrawing from the world, withdrawing from life. Now, in terms of death, there are really kind of two general pathways. There's the normal road, the usual road, which is illustrated on the left, which someone becomes sleepy, lethargic, obtunded, and moves towards death. That's a peaceful road in general. But often, the patients who get brought to the emergency department are the ones on the more difficult road. The patients who experience something else. They go through a restless end of life. They have hallucinations, delirium, agitation, maybe even seizures. And often patients who take this road towards death are the ones whose families don't handle it at home and bring them to you in the ED. So how are you going to manage those symptoms? Now, when we're faced with a patient at the end of their life, they may have a life-ending condition. This could be something like an infection, a urine infection, pneumonia. They may be dehydrated, have an electrolyte abnormality. What is the course of action that we should take for these patients in the emergency department? Well, first, the big priority is make sure patients are comfortable. So to treat any symptoms that are distressing them, that are bothering them. And then we need to decide what this patient wants. What does the family want? What are their goals for the care of this patient? We need to give our recommendations, give our advice, and we need to decide together, partner with the family, what the consensus is going to be. So we're working together to do the right thing. Now, this can be done really three ways. The first option is to really do not very much. We're not going to intervene very much. We're going to do things that make this patient more comfortable, and that is our goal. The second option is maybe we might do some things that are not very invasive, things like we might just do a chest x-ray, we might order some basic blood tests, maybe we'll give some antibiotics. Or sometimes we choose we're going to do everything possible. We're going to recommend surgery if they need it. We're going to recommend CPR if they need it. Or the family wants those things, and we have to resolve the conflict if we don't necessarily recommend those things. And there's an art in the skill of communication when you want to make those recommendations. Some things that families are really concerned about at the end of someone's life are these kinds of things. Is my family member in pain? Are they suffering? Can they hear me if I'm talking to them? What about food? What about water? And what should we expect? When might the end come? And we don't have often excellent answers to these questions, but these are the kind of things our patients want to know. So we have to be somewhat prepared to discuss those things. But one recommendation I have for you is to never say that we're withdrawing anything. We're never going to use the negative words. We're going to use positive words. We're going to do everything we can to make sure that your father is comfortable. We're going to do lots of things to make sure that their symptoms are relieved. We want to talk about the things that we're going to do, all the care that we're going to give. We're not going to talk about the things that we're not going to do, because it makes families feel guilty. You feel guilty if you choose not to do something for someone. It makes you feel like somehow you don't care. So we want to recommend in a positive way all the things that we think are appropriate for the patient. Now, this is primarily going to be about symptom control and making sure someone is comfortable, not in pain, and not suffering. And there's a lot of medications that we can use. This is the art of medicine. There are a lot of different options here. We're going to talk about some of the options. In terms of pain, a lot of people are afraid of pain at the end of life. Families are concerned about that. And when patients are relatively unconscious, think about the patients in the ICU on a ventilator that are hard to assess, we still can look for signs of pain, right? We can see their faces tighten up. We can see their respiratory rate increase. We might see their heart rate increase. There are ways that we can tell that someone is suffering, and we should be aggressive in addressing their pain. This needs to be distinct, though, from the terminal delirium. The patient who's having dreams as they're exiting the world may not be in pain. Sometimes we can't tell the difference, and we're going to treat both because it's hard to tell. There are other things that we can do to relieve someone's pain besides medicines. We can reposition them. We can move their joints around. We can help do those things that make them feel more comfortable. Put a cool cloth on their head. Those things are very important at the end of life to make sure someone's comfortable. Now, sometimes we're very used to giving patients medication through the IV, right? That's how we're often doing things. And in these patients, that may not be the right thing. You can picture the nurse trying to find the IV on the patient who's dehydrated. They're poking and poking, and the patient's in pain. Is that the right thing for this person? Maybe not. That may not be in their goals of what they want at the end of their life. So are there alternatives to giving IV medication for everything? And the answer is absolutely, absolutely yes. If you don't have an IV access, you can give most of these medications orally or even rectally, sublingually, lots of different mechanisms, even subcutaneously without the IV. Lots of ways that we can do this. One way is to insert a very, very small gauge needle just into the sub-Q space. This could be in the abdomen or in the chest. And we can infuse our opioids, our benzodiazepines, all of our medications, even IV fluids that way. It looks something like this. This is a small needle inserted in the chest wall, and we call this clysis, which is basically giving subcutaneous IV fluids to patients at the end of life without putting in an IV. This is pretty easy to do, and those fluids get absorbed. And this may be a good way to go. Patients often at the end of life have a very dry mouth. As you near death, you start to experience less hunger and less thirst. But your mouth appears very dry, and this often makes family members very concerned. They look thirsty, doctor. Shouldn't we give them some fluids? Well, the truth is that what we need to do is actually do more oral care. So we could use moisturizers, we can use swabs to give saline on the lips to make it look a little bit less disturbing, but often people are not suffering from a great deal of thirst as they start to die. We also may need to talk about feeding tubes and artificial hydration. We'll talk a little bit about that. And that could be things that you may not be deciding on in the emergency department, but they may ask you for your recommendation. So how much do you know about those medical therapies? You know, these sometimes to families seem like what we should do, the right thing to do. But don't forget, with every medical intervention, there's always risk and benefit. There's always a decision to be made about what the goal is of the therapy. Putting in a G-tube or a feeding tube is not without its risks. The tube can come out, the tube can get infected, and in fact, patients who have feeding tubes can also aspirate as well. And so thinking about these makes it not necessarily a straightforward decision. IV fluid as well, as patients as they come to the end of life, can also third space. They can become edematous. They can't necessarily hold that fluid in intravascular space, and it can do more harm than good at times. So it's not necessarily always the right thing to do. In fact, towards the end of life, we believe that giving IV saline doesn't necessarily make people less thirsty. Their mouth will still be dry because their body is in the process of shutting down. And so this may not be the right thing to do. As someone nears the end of life, if they're very agitated, we can use the therapies that we're pretty comfortable with. We can use lorazepam, midazolam, benzodiazepines to soothe the agitation. And these don't have to be given IV. You can dissolve them, you can give them in the buccal mucosa, you can give them rectally, you can give them subcutaneously, lots of different routes that you may not be as comfortable giving these medications. Haldol is another drug, haloperidol, that can be used for agitation as well, and it's very useful for patients at the end of life who are having disturbing agitation. Sometimes patients who have this terminal delirium or agitation may have it because they have something reversible. There may be an infection, there may be hypercalcemia, there could be a metabolic abnormality. And the decision has to be made about whether we're going to look for that and whether we're going to treat that, and again, if it's within the goal of care. And at some point, we may not treat the urine infection that keeps coming back. We may make a choice not to do that. But we may make a choice on this visit to do it. So we have to talk about whether or not that's something we want to do. Patients at the end of life often appear very short of breath. Dyspnea. How do we treat that? The first line of therapy at the end of life is opioids. Using morphine is the first line of therapy. Sometimes we reach to put oxygen on, and really there's been several studies to look to say that oxygen at the very end of life does not prolong life. It may make the patient feel less symptomatic, but really the oxygen's not doing very much. You could just put normal air through it, and that might be just as helpful. You could also use a fan, things like that, that are interventions to make people feel more comfortable. At the end of life, I mentioned that people sometimes have a hard time swallowing or handling their secretions, and as they breathe, they have this noise that we call the death rattle, which is this gurgling sound that is very troubling to families. They feel like their family member is choking, and they want something to be done about it. Well, you can do something about it. You can give medications to dry up those secretions. My favorite is the top one, the glycopyrrolate, which is like atropine, but it doesn't cross the blood-brain barrier, and it can anticholinergic that dries secretions. And you can see that you can give this many different ways. If you give it subcutaneously or IV, it acts in about 1 minute. It will help dry up these secretions. There are other options as well, mostly anticholinergics that can help dry up these secretions and take away this sound. Now, as someone's getting close to death, of course, we would rather not manage them in the emergency department, but sometimes, as we talked about with Dr. Vecellio, we have no choice. There is no place to put them, so we have to deal with it. And communication and talking is a huge part of this. Communicating with the family, explaining what's going on, explaining that what their family member is going through may not be identifiable to you. What they're experiencing may not be exactly what you see. They're in their own world at this point. And we have to talk about those physical signs, what we think is going on, what we can do to help them be more comfortable. And then we want to ask questions about what this person, what this family would like at the end of life. They might want a priest. They might need some support. They might want to play music for this person. Those are okay things. They're very unfamiliar to us in the emergency department sometimes, but those are the right things to do, and we can make that happen. And we're going to be supporting the family. Because as somebody's dying, our new patients are the family, the survivors, and we want to focus our attention on them and their comfort and what they can be helped with. There are a lot of things that we are used to doing in the emergency department that are not the right thing to do for this patient. So this person doesn't need a cardiac monitor. We're going to turn off the monitor. We don't need to know those numbers. It doesn't matter for this patient. And sometimes it can be more upsetting to a family to see the blips go down to 0 or hear the alarms going off and off. So turn off the monitor. This patient doesn't need a cardiac monitor. This patient may not need blood draw or the routine chest x-ray or vital signs every 2 hours or 4 hours because it may not matter. That information may not change what we're going to do. So we have to rethink some of the basic routine things that we often do in the emergency department for this patient to make sure they're comfortable. If you can, you want to try to find the most private place possible in your emergency department, which may be a real challenge, but to try to find a quiet place where this family can gather and be with their loved one. If you can try to get them upstairs to the unit, the ward, that's fine. But this may be someone that you've really got to think about, how is this going to happen for them? This is a very unpredictable thing. I've seen patients where I thought they were going to die in the next hour and they lasted another 12 hours. Or people who I thought wouldn't die till tomorrow die in 2 hours. I mean, it's just very hard to say. And I think it's important to be honest with families about that. I don't have a crystal ball. I can't tell you exactly when this is going to happen. I just know that it's coming soon. And so that's okay to be honest about. And you want to just keep talking to families about what we're doing. Many hospitals in the United States are making these kinds of units that you see here. This is a hospital room, but it doesn't have any machines, it doesn't have any monitors. It's just a comfortable place that looks as much like home as possible where we can take care of a patient who's dying. So in summary, there are patients who are going to be dying that are going to be brought to us. We have to be able to recognize when people are almost at the end of their life and to reorient ourselves as to what we're doing for them. We should rethink the routine, regular things that we do in the emergency department to make sure they fit the goals for this person. And you gotta do what you do best. We are very good at managing patient symptoms. We're really good at communicating with families. And so these scenarios actually play into a lot of our strengths. For those of you who have ever had this experience helping someone die at the end of their life, it's one of the most rewarding things you can do in medicine. It's a very wonderful experience to feel that you did the right thing for your patient and you helped this family. It's not necessarily emergency medicine, what we get excited about, but in terms of being a physician and a healer, it can be one of the most rewarding things that you do. And when you know how to do it and you have these skills, it can make it even that much better. All right, thank you.
Tenemos tiempo para preguntas.
Here. Okay, doctor, hello. There's some times that we, when we're in the emergency department, that we receive some really critical patients, severely ill patients, and most evidently, just when they arrive in there, we realize there are some patients that has, I don't know, maybe Alzheimer's, or they're institutionalized, and you know that they'll have a bad prognosis or they don't look really well. These patients also, many times, don't come with their families, or they're unconscious. And you have to take some time decisions, some critical time decisions, and you have to put in a way, you know, if you do some critical things, some invasive procedures, or if you have to you know, let the patient just stay. What would you do, or what do you recommend in that time with those patients in which you have some time decisions versus no family income, no something? What would you do then?
Very good question. A very common scenario, the patient who's brought in that's clearly cachectic, Alzheimer's, end of life, and this patient's dying, and you don't know what their wishes are, and they can't communicate to you what they want, and you have to make a decision. And we are often afraid to not do anything because we don't want to get in a fight with the family when they finally arrive or finally become aware of the situation. My best advice, what I try to do, depending on the situation, is to try to temporize, to try to buy some time to find the family. So whether it's using BiPAP or non-rebreather mask or positioning or whatever I can do to try to not intubate this person, to have time to talk to the family about what the right thing to do is. Sometimes it will turn out that you will not have the family and you have to make a decision. And this is a very troubling decision for physicians, and I think that we each have to do what is ethically right to us. It is within your purview to make decisions about what is medically necessary for that patient and what's the right thing to do. Sometimes it is okay, give yourself permission, it is okay sometimes to intubate the person, that you don't have the family to make a decision, to give them the time to come and be part of it. That's okay. And you can take the tube out when you have families and you have time to make a decision. And sometimes you have to do that. Even though you know it's not the right thing to do at the moment, you have to give the family space to accept what's happened, to grieve, to talk about it, and make a decision with you. We always want to try to give our care on the same side of the patient's family. We want to be partners with them and not arguing, not being adversarial. So as much as we can do it the best we can for that patient, we can. It's not an easy question, and there's not an obvious answer. But the best recommendation I have is to try to make time so that you can find the family as best as possible to do the absolute right thing.
¿Otra pregunta? Bien.
Thank
Muchas
you.
gracias, doctora. La siguiente conferencia es de